This is Michael Smith of MedPage Today. I'm in Washington at the International AIDS Conference, and I'm speaking with Dr. Julio Montaner, a former president of the International AIDS Society and the director of the BC Centre for Excellence in HIV/AIDS. Dr. Montaner, welcome back to MedPage Today. We've chatted with you many times over the years.
My pleasure, Michael.
I am interested. You were one of the pioneers of this notion of treatment as prevention, the idea that if you treated people with HIV, you could prevent transmission of the virus. And you now have some very important luminaries on your side. The Secretary of State of the United States, Hillary Clinton, puts this as one of her 3 pillars in a program to end AIDS, although not to cure HIV, of course. It's all very well to have the stars on your side, but surely this is not a slam dunk. What are the obstacles aside from the resources, aside from money?
As I said earlier this week, the notion that treatment prevents morbidity, mortality, and secondarily, for free, has an additional preventive benefit when it comes to HIV transmission, and tuberculosis, by the way, is simple. The problem, the challenge, is that the implementation is going to be complicated. It's complicated because it requires a concerted effort to bring testing and treatment to the people. Often people who may have other challenges in their life that make it difficult for them to make this a priority, particularly at a time where they're not feeling the consequences of the HIV infection. I deeply believe that we will not succeed on this AIDS-free generation rhetoric or anything similar to that until we fix the healthcare system. And I'm talking about a major revolution here. We will need free drugs, free testing, supportive environments, facilitated access to treatment, and most importantly, we will need to deal with the stigma, discrimination, criminalization of HIV and related conditions. And I'm not now going onto a tangent. I think we succeeded in demonstrating that this can be done, that it should be done, but people are dreaming in Technicolor if they think this is as simple as test and treat. Everything else has to fall into place. We cannot do this in a fractured environment as we currently have it. And I think people are starting to realize that. The Gardner paper that showed the engagement in the cascade of care in the United States is an example of how broken the system is, because it shows that out of the 100% of the people that are potentially HIV infected in this country, only a minority of them, at that time it was less than 20%, it has been revised to less than 30%, but it doesn't really matter. 30% is unacceptable. We need to bring this number to something like 2, 3-fold what it is, and that is going to require a lot of work to fix the system. Now,
when you say the 30%, that's 30% in care and with their virus suppressed.
Correct. 30% of the people infected with HIV in North America are estimated to be suppressed, virologically suppressed, or antiretroviral therapy. That's not good enough, particularly at a time where the DHHS guidelines or the ISUSA guidelines are recommending that we should be offering treatment to everybody.
Yeah. But if you offer treatment to everybody and they don't take it or they don't stay in care,
absolutely,
the benefits are lost both absolutely. To them and to the general public.
Absolutely. And one more reflection on this issue. We cannot solve this problem by treating the people that we like only. We need to treat them all. We need to bring the services to all. That means people with mental illnesses, people with comorbidities, people who use drugs, commercial sex trade workers, everybody. If we don't embrace those populations, which means that we need to have a social reform from the legislations to reforming the healthcare system, because these are the people that typically do not engage with the healthcare system because the healthcare system is hostile to them.
Right. At this meeting, there's a lot of research showing that this treatment as prevention actually has an effect in the real world. And you have a study in your own province, your Canadian province of British Columbia, that deals with that, and I'll get to that in a minute. What are we seeing in places with high prevalence, where there's a lot of HIV? What are they finding when they go out into the real world and try this?
Well, you can take examples from a variety of places. China, KwaZulu-Natal, others. They are showing that, as we've seen again and again, the greater the coverage with antiretroviral therapy, the greater the effect that you see in terms of decreasing morbidity, mortality, and importantly, transmission. And so the evidence is overwhelming. Wherever it has been looked at, the evidence is there. Of course, in areas where the programs are weak, you may not see this effect. But in general, we have seen no, let's say, side effect or contradictory results. There has been no risk overcompensation or a backfire because of this strategy. The strategy works, is very sound, and the better we do it, the better it works.
Mm-hmm. Some people have argued that this is all very well in a place where the risk of acquiring HIV is high. And I want to come back now to this study that you guys are doing in British Columbia, which is has a population of something like 4.6 million, spread out in a fairly large area, a couple of large cities, and a fair rural hinterland, but a fairly low prevalence of HIV. Describe the study that you're doing at the moment, and then we'll talk a little bit about what you're seeing so far.
British Columbia has an estimated 13,000 people infected with HIV. Predominant group is the MSM, second group is IDUs. We have now shown that at a provincial level, by rolling out antiretroviral therapy aggressively, every time that we step up the number of people on treatment, the number of new infections that we document decreases. And most importantly, we have shown at the same time that every time that we expand, we decrease the frequency of AIDS and we decrease mortality associated with it. The truth is, in British Columbia, we have nearly eliminated AIDS and HIV-related mortality. Mortality is down by 95%, morbidity is down by greater than 85%, and transmission is down by approximately 65%, both in the community as a whole and also in injection drug users. So this works for everybody. But the trick is this: we have the most liberal approach both to support and treatment of addictions. This is critical. We have a supervised injection site, we have free clean needles, low threshold services, and if we don't have that, there would be no way that we can engage this population.
And of course, one of the things that you brought up at the beginning is you need a healthcare system that works. Undoubtedly, the British Columbia system has some flaws, but it probably works better than in some African nations, for instance.
Well, of course.
You have good doctors, you have access to care, as you say.
Of course. I mean, we are lucky enough that we have good access to services, and more importantly, we're the only province in Canada that has antiretroviral therapy completely free, no copayments, no deductibles, no nothing, and all of the laboratory services, specialized and non-specialized, are all free. Doctor visits are free, completely free. There is nothing that is going to act as a disincentive. And in addition to that, we, working with the provincial government, have come to an agreement that investing more in outreach and services for people infected with HIV is actually highly cost effective. So we're now bringing the test to the people, we're normalizing the testing, we're changing the question around the testing. We're not asking people to test to confirm that I'm positive. So there is no more finger pointing that you are going to get the test because there is a problem with you. No, we're saying if you have been sexually active once in the last 5 decades, we want you to test. And as a result of that, people are coming forward to test that have no risk. Why? Because we have engaged the population on a campaign to truly eliminate HIV.
It sounds like that sort of thing might work in a number of places that we know. And of course, as you say, there are many obstacles around the world, including lack of excellent health care. Thank you, Dr. Montaner.
My pleasure.
In Washington, I'm Michael Smith, MedPage Today.